Center, which is in Fremont. We also have Jenna Haggerty from Metro Health, which is a verified level 2 in Grand Rapids. And I think I'm missing somebody. I don't have the agenda in front of me. I may be missing one person. I apologize. I'm doing this from my phone. Tara, are you on the line?
I am. Good morning.
Do you want to get us started, Tara?
Actually, this is Yvonne. Helen, can I just insert? I'm sorry, I had trouble connecting.
Okay. Sorry, I introduced folks.
Oh, did you? You introduced everyone? Yeah. Did you talk about purpose and all that?
Yeah, a little bit.
Okay. All right.
Well, then if you want.
No, let's just go with Tara then.
I think I may have forgot somebody because I don't have the agenda in front of me. And
okay. We have Mo from Highland. She is representing a level 4 at Highland Hospital. We have Lindsay from, what's that? Oh, level 3, yes, I'm sorry. Lindsay from Spectrum Ludington, level 4. Dr. Hoffelder, Fremont, level 4. Jenna from Metro, level 2. And Tara from Aspera, Ionia, level 4. So we have every level that Michigan has except level 1 represented, and then our EMS contributors at the very end. So, so yes, Tara, if you're
I'm Jennifer Haverkamp. I'm from Butterfield.
What's that?
I think
hello?
This is
I'm not hearing it.
Can you hear me okay?
Now, maybe.
So this is Jennifer Haverkamp. I'm from level 1.
From the Children's Hospital. Yes, thank you.
Thanks.
So Tara, if you are ready, we'd love to hear from you.
Sure. Good morning, everyone. My name is Tara Lons. I am the Emergency Department Manager and Trauma Program Manager for Sparrow Ionia Hospital. I'm also the Director of our Medical Control Authority. We're a single hospital, single county MCA, so I'm kind of integrated into the EMS system in that fashion. So in terms of how we integrate EMS into our trauma system is a little easier on a small scale. So we involve them in our trauma PI subcommittee, and we provide feedback. Some to most of it is informal because I see most of my medics on a daily basis. When I asked them what was important to them for feedback, they responded, did the person die and did I miss anything? So some of what they want is pretty basic. They're not looking for in-depth review necessarily, but they're just looking for the basics of did I miss any injuries and what was the outcome of the patient? And so we do work to provide that on a monthly basis or at their request or whenever we run into each other. But it is very valuable to be able to provide some loop closure to them for the care that they provided. And then, yeah.
I apologize for interrupting. I just want to let everyone know I am going to mute everyone else because there's some background noise going on, so that way everyone can hear Tara really clearly.
Thanks, Courtney. So we, in our PI meetings, they are involved. We only have 2 agencies, so like I said, being small is pretty beneficial. But we do look at scene times and the care that they provide on our trauma patients and give them feedback during that meeting to be able to meet our goals for quality for care of the patient with traumatic injuries. So I think that that's just a brief overview. A lot of our process is informal, but while it's informal, it's still very important to be able to give that feedback and loop closure.
It looks like Lance has his hand up. Did you want to hop in now, or did you forget to put it down?
No, I was just going to let all the EMS providers know that there'll be a link in the chat at the end just to access the survey so they can receive their credit. So,
Thank you.
I think that's all I have, Yvonne and Helen. If anybody has questions for me, I'd be more than happy to answer it. Our being a smaller system probably looks a little bit different than other places.
Hey Tara, this is Dave Hoffelder from Gerber. Did you say that you provide feedback on every trauma patient, or just when there is a PI concern?
Just when there's a PI concern for the most part, or when, you know, they ask like, hey, how did that person do? Or did I miss anything? Higher level activations are usually requested, or they'll want to know the outcome, things like that.
Sure. Thanks.
Mm-hmm.
Yvonne, do you want to take back over? Yvonne, I think you're having some major lag, or we're just not being able to hear you if you're trying to talk right now.
I think she's probably having some connectivity issues. I guess in the interest of keeping things moving along, I don't remember who is next on the agenda. If somebody wants to jump in next to go, otherwise then I'll volunteer to go next.
This is Mo from Holland Hospital. I can go next.
Okay, cool.
So our feedback is similar to Tara's, where most of it's done through feedback letters or in
John
real.
Elkma calling from Wright Talmadge Fire Department. How you doing? Oh yeah.
So as I was saying, most of our feedback is done through follow-up letters or in real time. So I try to do feedback letters for all of our level 1 activations, any cases that may be interesting, ones that I know that they're probably going to ask on requested feedback. That's what we do. We usually do letters every 1 to 2 weeks just to try to do it as close to real time as possible, because I feel like it's a little bit more meaningful if they can remember that call. And then any PI concerns too, like C-collars or scene times, destination protocols are some things that have come up. If there's anything I'm unfamiliar with as far as their protocols, I make sure to look it up first before I'm sending feedback, or ask leadership, agency leadership about it before I send a letter. And then as far as in real time, I try to be out there anytime we have a trauma activation. If I'm in-house, I try to go out and help so that I can be a part of the process, and they know who I am and they know who to ask questions to. I also do feedback with fire and police as well. And we try to reach out to them too if there's a particularly traumatic one, as far as, you know, maybe it was a pediatric patient or prolonged resuscitation. We'll usually do like a critical incident stress management session, and we'll invite them as well. For another one, we had multiple PI concerns involving destination protocols and other things. We'll try to involve everyone in that. So we've pulled everyone as far as EMS, fire, and AeroMed together, and Spectrum, and done a complete review of PI together. They're not always invited to the committee to review cases, but if there are cases that maybe there's some pre-hospital things that we can talk about, then we do invite them ad hoc to our committee. So. That's pretty much all I have.
Thanks, Mo. Can you hear me?
Yep.
Okay. I was wondering, have you had EMS at one of your meetings recently? What kind of a case would you, can you give us an example of something that you might discuss?
So we haven't had anyone at our like our bi-monthly trauma committee meeting recently, but we did pull together a group. Like I was saying, we had one that was kind of around whether the patient should have been like aerometed out versus coming to Holland versus going straight to Spectrum. So that's a case where we pulled everyone together. We had to do it virtually, obviously, and we talked through. We pulled out call time to Aeromed because they were en route and what time they landed and what time the EMS left the scene, and try to determine would this patient have arrived to Spectrum sooner if they would have just waited on scene. So that's one way that we've pulled everyone together. It's been a long time since we've been invited to the actual committee, probably like a year or more pre-pandemic. So.
Did you find that meeting helpful, having everybody in the same room?
Yeah, absolutely. It was really enlightening for us to show the ways that we can work together and communicate better pre-hospital, because we were not aware that Aeromed was en route to the scene when they decided. So the patient was deteriorating on scene and there was nothing more they could do. So instead of waiting another 10 minutes for Aeromed or so, they decided to load and come to the hospital. So from doing all of that in the timeline, we were able to determine the patient actually would have gotten to Spectrum an hour prior to what happened, because when you get into the hospital, now we have to stabilize this patient. They put in an airway and confirm placement, and there was just a lot of things in order to get that patient back out the door. And then we actually do not have a helipad at Holland Hospital, so then we actually have to get to the airport with this patient, coordinate that with it actually wasn't Aeromed, it was Air Care, because Aeromed wasn't available that night, I believe. Or actually, there was 2 calls that night out in Saugatuck, so they were both out, Aeromed and Air Care. So it was just a lot of things happening on that night, and so it was really helpful for us to dissect that together and see where we could improve. So yeah, it was great.
Thanks. I don't know if Yvonne is on yet, but Dr. Hoffelder. Go ahead.
Yeah. Well, can you hear me now?
Yes.
Yes, awesome, thank you. So yes, let's proceed with Dr. Hoffelder. I'm sorry, I logged off and started it all over again. I don't know what was wrong. But Dr. Hoffelder, and thank you for all just jumping in and going ahead.
Yeah, no problem. Thanks, Yvonne. I have the standpoint from the trauma medical director, and I don't have as much in-depth knowledge of the PI process as far as just the intricate details as my trauma program coordinator does, Susie Gatrell, who's on the call. But very similar to Tara and Mo as far as a single hospital, single MCA. We're a fairly small community, and we have a really good relationship with our EMS providers in our county. And I think it really takes that. It's a two-way street with regard to the communication. As far as trauma PI goes, we provide feedback to EMS when it's requested by them, and they'll usually request that on the typical cases that have been mentioned thus far, level 1s, kind of rare events, significantly injured patients. And so we'll provide when requested. We'll also provide feedback when there is a PI issue that we need some feedback on. When we do have a PI issue, then that's taken to the EMS medical director. And then that information is taken to the local MCA, where it is discussed, and then eventually, just in the nature of loop closure, that's all brought back to our trauma operations committee at Gerber, so that we can loop it into the PI and close everything out appropriately. Specifically, a little bit of a deviation. I think Mo alluded to this as well. We've had a couple RCA events over the last couple of years since I've been trauma medical director, where we've had EMS input. And obviously this was all pre-pandemic, but just to give you an example, some rare cases, one was a gunshot wound to the femur, and actually did not hit any great vessels, but the patient exsanguinated essentially on scene. And so we definitely got feedback from EMS. We even had the medical examiner who was present as part of the RCA to explain how this event really happened, and it was just kind of a perfect storm. And so EMS loves that feedback. Obviously, it was a sad case, but just to be involved in part of the team and part of the communication, and they obviously give valuable detail on what's going on the scene. Some things that just can't be verbally communicated in the short time when they give us report can be gleaned through verbal requests for feedback from things going on at the scene. And so communication is definitely important with regard to that. But getting back to the RCA events, we've had the one specific gunshot wound, which is a rare event in Newaygo County. But then we've had some kind of difficult transports that involved EMS with motorcycle accidents from the scene that then got stabilized with splenectomies in our operating room, which is a pretty big deal for a level 4 facility, and then Aeromed transported out to Butterworth Hospital. EMS is intimately involved in those cases, number one, from the pre-hospital transport, but then like Holland, we don't have a helipad on site, and so then there's another bridge to get to Aeromed that EMS then has to pick up the patient from our hospital and transport them to the school about a half mile away so that they can then be transported out. So they are a key member in the transport of our patients. And so giving them feedback is really important for their learning, their engagement, and the improvement of our trauma program. I guess I'll stop right there if there's any questions from anybody. Specifically about the RCA, Susie developed kind of our standard form for the RCA, which includes all the members involved, such as in the last case, if it's a patient that went to the OR, there's the surgeon input, OR staff, obviously ED nursing staff, physicians, input from everybody involved, EMS as well. The concerns are discussed, and then there's follow-up actions for each contingent as it pertains to how they were involved in the case.
Thanks very much. I invite people to ask questions. Let me just, for everyone on the line, because it took me a while to get around all the acronyms we use. We talk about PI standing for process improvement. And so I just want to be sure that we're not using terms that everyone doesn't have an understanding of. So we have this continuous goal of saying, how did that go? Could we have done it better? Really, and then how can we make changes, monitor it, and then create loop closure, meaning being sure that it could go better the next time. So really, in a nutshell, that is what we refer to as PI. RCA is one of the steps we might take in that for a bigger analysis, as David refers to, meaning root cause analysis, and as he explained, interviewing people, to look for systems issues, to look for what really were the things here that we could address, that we could get a better outcome. And so thanks for using those examples. And most of the time, it really is just approaching someone saying, tell me about it. It's not about drilling them with a lot of different questions. It's just opening the conversation and saying, tell me what happened, and just taking a lot of notes to try to figure out what was going on at the time. I think it's really easy for us, and maybe something for us to, do what we call Monday morning quarterbacking, but we weren't involved. So really just having that very open mind to say, what happened? Tell us what happened. Any questions for Dave at this point? Dave, you were going to talk about some of the challenges that you find as the ER and medical director for trauma in giving feedback or connecting with EMS? What are some of those barriers that you've come up with?
I think that I would say probably the biggest barrier that we've identified, and I think it was maybe Tara that brought this up, is that the aside from the MCA feeding back into our trauma operations committee, the EMS really doesn't sit on our trauma operations committee. They don't sit on any of our emergency department committees, and so it is a little bit of a disconnect with us being an in-hospital program, and then there's the pre-hospital side of things. And so I think that is a big challenge as far as the flow of information, especially when they don't directly sit on one of our committees that we can kind of loop them in. And I don't know if other sites do that better. I'm sure that other places do it better than we do, and that's an opportunity to improve. But we do keep the communication open, and I think that on the critical cases and the cases where they really request feedback, then we do a good job of getting that feedback back to them. I think that one thing that we do well is have a great relationship with the EMS medical director, Jeff Stockhill, for life in our county, and that makes things a lot easier. Not everything has to be a big formal process. I can just pick up the phone and call them and get some feedback, and that makes things a lot easier. But you know, as far as me evaluating our kind of PI and how that works, then I think that's what the point of this whole education session was a better way to integrate EMS and communication into our PI program. And so I'll be thinking about that, and I welcome other people's opinions on that as well. But I would say that's probably the biggest challenge. I think things would be easier if they were just kind of sitting on the committee at the right hand, so that they could give feedback on cases, you know, in real time when they came up at these meetings.
Great. Any questions or comments for Dave before we move on?
My comment is just that I'm not sure that there are places that do it better. It'd be interesting to hear, but just, you know, talking with some of my other colleagues around the state, I think probably an opportunity for everyone.
Great. That's a great segue to Jenna, who is our EMS coordinator here at Metro. And we don't do that for trauma as much, but as she talks about how she connects with EMS about trauma, Jenna, I'm going to ask you to talk about how you do incorporate EMS into the stroke reviews, because I think we could learn from that.
Sure. Can you hear me okay?
Yes.
Okay. So I'm Jenna Harity. I'm the EMS liaison for Metro Health. Been in this role for about 3 to 4 years now, but similar to everybody else, when providing feedback, I have kind of a standard form that I like to use that just goes over findings, interventions, length of stay or outcome for the patient. Something else I like to include on there is kudos for the providers as well. I think we often can nitpick, but don't give kudos enough to everybody for the good job that they're doing out there. So whether that's just including, quick scene time, early notification of a patient coming in, reassessment and updated vital signs in GCS, really just different things. And then also if there's areas for improvement. And usually when I go through that process, I obviously review the run sheet and the findings and report when the patient was passed off to the hospital staff. I also will touch base with our trauma team. I work pretty closely with them just before I provide the feedback to say, was there anything else that came up in your weekly rounding that maybe I missed or that was identified by your team as well? And again, I try to do that for all the higher priority patients that come in or just the interesting cases. I also try to be present in the department when we have a high priority trauma coming in. Again, just to keep those lines of communication open, to say, you know, how'd it go? How are things on scene? You know, was there any barriers, anything you need from us too? And I often see, you know, the crew, if they're able to, will stick around a few minutes and, you know, even chat with sometimes the trauma surgeon that's there just about the case to make sure they were on the right pathway and with their findings as well. I think that the feedback forms for me also help look for trends or, again, barriers, to say, is this a trend that we're seeing that maybe we need to provide more education on? Are there any barriers in the system, whether it's equipment or anything that could help improve this process as well? And if there are trends, you know, I've done just kind of one-page educational sheets, or if there's an interesting case that maybe might have been a missed injury, but it's a very uncommon injury you see, you know, I'll provide like a one-page educational sheet in our EMS room just for everybody to see with a quick glance over. And then also we do EMS lecture series here that involve our stroke, cardiac, and trauma program. So our surgeons will speak, and sometimes, again, if we see a trend in an area or an interesting case, they'll do a case presentation, just providing that education and why it's important. But also, like everyone else, I want to echo just how big of a role EMS has in, you know, for our patients, and how big of a part of our team they are. So that's something else that we do. When Yvonne kind of just mentioned what we do with stroke here, I want to say it's quarterly, but we started doing just a quarterly meeting with, we call it our pre-arrival or our arrival team, transition of care for stroke. And we have really leadership from EMS, but we've had also providers who are involved in the cases. And usually the stroke team will pick about 4 to 5 cases to present with their images, kind of findings, diagnosis, and really outcome for the patient. But it also allows us as a facility just to talk about some of our metrics and how we're performing, allowing them to answer questions. There's been good feedback and really good conversation that has come up on either changing, you know, process between, you know, pre-hospital care or, you know, when they arrive to our facility. And there's been really good feedback just on the case reviews and seeing the images and, you know, being able to pass that along to the providers as well.
Any questions for Jenna? Jenna,
I think this is Jenna. Oh.
Yeah, go ahead.
Quick question for our EMS colleagues that are on the phone. One thing we struggle with, I'm sure like everybody else, is sometimes getting participation. You know, I have my lead contacts at the agencies who I can often get to, you know, show up and participate, but we know it's a lot to ask of others to be doing extra on top of, you know, their scheduled shifts. So I guess looking for advice on how to get that participation and get that involvement from the providers that are on the trucks, just to make sure, you know, that information is being relayed and they, you know, are feeling involved as well. So I'd be open to just some suggestions or, you know, the best approach or how they'd like to receive that information.
There is actually going to be a specific time after Lindsay talks where EMS is going to contribute. So is it okay for us to delay that question to then?
Oh, sure. Sorry.
No, good. That's okay. That's okay. We don't have a published agenda up. So think about the questions we want to ask them as well. Anything else for Jenna that you'd like to hear more about what she does? She's more than willing to share. I know lots of you are, the form she uses to give the feedback to EMS as well. So Lindsay, looking forward to hearing from you.
Hi, I'm Lindsay. I am the trauma program coordinator for Spectrum Health Ludington. You guys, a lot of people already talked about a lot of the stuff that we do. So we are a very rural hospital out here in Ludington. We see about like 250 to 290 trauma patients a year. Within our PI program plan, we do have some specific things laid out for EMS. That's things the pre-hospital that we do review and evaluate and discuss at our trauma committee meeting. So we look at all, of course, all pre-arrival care, looking at things specifically like Jenna was saying, you know, with the GCS and the extrication times, any bypass diversion events. We look at all of those it's to see if there's any kind of PI issues, the notification, prompt notification times. So those are usually like kind of like the highlighted things we talk about. We do provide feedback to EMS on kind of like the basis of what everybody's been talking about if requested, and just a lot of informal kind of at the bedside. I'm present at all the trauma activations when I'm here on site, and we kind of to make sure we do our briefing and all that right then in the moment. We like to do that. But anytime they request, we're more than happy to provide feedback. We've actually just invited Jeff Stockhill to our trauma operations to kind of start get that going, because we have realized that we do have a bit of a gap here with providing feedback on a consistent basis. So we're hoping that he'll be willing to attend with us to kind of give us maybe some ideas of what they would like to receive and how they would like to receive it, how often, and that sort of thing. Kind of just like Tara said at the beginning, mostly when they do ask and approach us, it's did they die? Did they make it to their destination? How, you know, those sort of questions that that they really are interested in knowing. Did they provide good, you know, if we found any gaps in their care? How do I want to say this? We do work really close with Jeff and Jim on making sure that we get 100% of the run forms, so we can look at all the cases. A bit of our issues out here being kind of so far away from tertiary center is where do we go with the patient? Like, do we go to Mercy? Do we go to Grand Rapids? Depending, AeroMed from the scene, or if they're going, we do have a helipad here at Ludington, but we often have such bad weather with our snow and our precipitation that often they cannot fly. So that's a bit of our issue. And then transport times too, because it does take, when we have limited rigs, getting them off the road for a couple of hours when they have to transport, you know, on a couple hour ride to Grand Rapids. So that's a bit of our struggle. Trying to think what else we do. We do our PI. I sit on the MCA as well, and so if we do have an issue or a concern with pre-hospital, we will keep the key players kind of after that, and do like our PSRO and discussions, and if we found any opportunities for improvement there, and then kind of go to see where the next steps are. Since I've been doing this role, we haven't really had very many, maybe 2 concerns that have came through. So that might be something too. I'm not sure if we're not getting reported maybe, or if everybody knows the process to submit us those concerns too. So that might be something, if maybe education on how to submit those concerns, so we could look at more. I think that would be helpful for us. What else do we do? I'm trying to think. We do invite EMS, same with fire, DNR. We've had some kind of sad cases lately with mortalities, so we'll do the CISMs, or the critical incident stress management briefings after, and so we try to include everybody with those. What else? Oh, we do quarterly education with EMS, and that's kind of just like what Jenna was referring to. It's not just trauma, but more like stroke, anything trauma, anything really within our region that's been coming up recently. So that's not completely trauma specific, but just general education. But yeah, we are just looking for, really hoping to get out of this what everybody would like to receive back from us. So
Great. Thanks, Lindsay. Any questions for Lindsay? I think one of the things is just what common challenges we have and what common themes there are. Really, trauma across the continuum, regardless of our level, we are faced with some of the same challenges, but in our own setting. So that's a great segue to our EMS contributors. I don't know all of you that are on the line, but Lance has arranged for several EMS representatives to be a part of the conversation. And this is your time. We really do want to hear from you. Some of the things that have been raised is, what is the best way to communicate with you? How would you like to be involved? What is the most important thing that you want to know about a case after you bring it to us? What kind of feedback is important? How to get that feedback to you? How to get you engaged if you would like to be more engaged in our process of reviewing a case? So who would like to be first? I know that Lance is very good at volunteering you. And he knows who is on the line that he's asked.
Yeah,
This is Craig.
Sorry, I was going to say we have 16 EMS providers on the line, so really excited, but go ahead, Craig.
Yes, thank you for coming.
This is Craig Dodge with Life EMS Ambulance, and I guess I'll just jump in with a couple thoughts. If anybody knows the silver bullet of how to communicate effectively with the EMS providers and get them into better participation with things, I think we would like to know what that is, because it is very, very challenging. And you know, we struggle with it. We struggle with those same issues. And I think EMS is challenging because we are, by the nature of what we do, we are in a very disseminated type of business. Our people come in, they punch in, and then they go out on ambulances. Or they're in our rural counties, they're out there at stations in Irons, Michigan, and Baldwin, Michigan, Scottville, and they're just so separated. So it is very difficult to know how to communicate with them, even with the tools that we have available to us today. And there's also just the factor that we're dealing with right now of short staffing. So we're asking a lot from our providers, and many of them are working long hours. And so the last thing we need to do when they're not at work is bother them to try to do something even more. So it's just very challenging. And I think all of you do a good job. You've made reference to the good relationships that we have. I know many of you have very good relationships with any of the EMS leaders from all the different EMS organizations. And I think that's just the key, so that when there are concerns that are raised, and the positives as well. Everybody certainly loves to hear when there was a crew that did an awesome job on a trauma, and any of that kind of feedback that you can give through the leadership is extremely helpful. I very much appreciate the education that you guys do offer. I know many of the hospitals offer a great deal of education for the EMS providers, and I hope that you'll continue to do that, and we'll just continue to try to encourage our providers to participate in that stuff. So I guess those are some of my thoughts. I guess the final thought that I have that maybe doesn't need to be the focus of this meeting, but is just simply the whole situation with EMS staffing. It is bad, and it is getting worse. And I will tell you that I believe that we've been fortunate so far, that I don't think there's been any huge issues that I know of not being able to move patients, but I think we're getting pretty close to that. And I'm very concerned for the next few months of where we're going to end up. And I think at some point that's going to be something that probably all of us are going to need to spend some time talking about. So I'll stop right there.
Thanks so much, Craig. Who's next?
We have
May I
Mel.
have a question first?
Oh, sure.
You mentioned something about the restaffing issue, which I agree with you 200%, but also you said you are not aware of a patient being hurt. I can tell you several patients on my end that were delayed by 12 and 48 hours for extremely critical conditions, like necrotizing soft tissue infection, bleeding, and peritonitis. So actually, I think patients are getting hurt, and I would disagree to say that patients were not getting hurt.
Yeah, and I don't doubt that one bit. I guess I'm just saying that you probably see it more than I do, because you see some of those specific cases that I may not necessarily know about.
So I think, Yvonne, that kind of leads to a good conversation point about, is there a way to improve that loop closure? So when you do have those situations, it's not necessarily just about the initial transport, but it could also be as part of like an inter-facility transfer, just loop closure.
Right.
All right, we have Mel Oakley who's had his hand up. So go ahead, Mel.
Thanks, Lance. I wanted to dovetail off of one of the things Craig said about our staffing crisis and how we're having a hard time getting people not just into the organizations, but also to stay in the organizations. And I think that, while I don't have much magic bullets to offer to my peers here, as much as I wish I could find a box of those to share. One of the things that we do here as far as giving good feedback to our providers and having a street level, if you can excuse the term, providers involved in this process of process improvement, that I believe wholeheartedly is one of the things we can do to help keep some of our better providers in the industry and in our system. Is they leave because they feel unheard and uninvolved in the advancement of their patients' care and making sure things happen that are good. And that's why they go on to do things like become MCA coordinators, nursing providers, and things like that. They want to have that involvement. And sorry, my radio is going off here. What I think we can do by offering EMS involvement in this PI process here, which is not the right use for that term, but whatever, to improve the process. This is good. Let's keep doing this. Let's keep having EMS involved in this and having the providers who wear the boots and go out and run the calls involved in this as much as we can. That will help people like Craig and I staff our ambulances, I fully believe, is when they're able to be involved in these conversations. So this is good. I applaud this, and I'll shut up and yield the floor.
Well, thanks for participating, Mel. Someone else?
Can I have a comment?
Sure.
Just a comment on what was just said. I can tell you that unfortunately we talk a lot about EMS and we talk about them a lot, but they are unsung heroes of a lot of things that we can do. It's exactly like nursing, taking care of patient on the floor. They're also the unsung hero of patient care. But I can tell you my personal experience in Wisconsin that I was extremely close to our EMS system to the point that I used to have regular meeting with them every month or 2 months in one of the ambulance hangars. I used to rotate among all of them in north central Wisconsin, and we used to discuss difficult cases that they wanted to discuss or cases that I would bring to them either in a PowerPoint format or story format, and discuss cares and discuss what's new and what can be done in the ambulance and from the field to the patient. And I cannot tell you how happy and how engaged they were a lot. I can tell you, I tried to do that here. I got the door shut in my face a lot of time. So we cannot have it both way. People told me we know what we're doing. We are very self-sufficient. We do not need anybody to help us understand or give us any information or anything else. So I think people sometimes shoot themselves in the foot without knowing. But I agree with you. We are the provider and the hospital are more than happy to have engagement with EMS, but also EMS have to be willing to be engaged in this as well.
Thank you.
And
Can I hear from one of the firefighter representatives, please?
you read my mind, Yvonne. So Brian Stolzenberg from Caledonia Fire and Alpine Township Fire is queued up.
Hey, good morning, everyone. So I think to echo what Mel said and pretty much everybody else, I think the system as it is now, it works. And I think it's the constant desire for improvement is having a trickle-down effect. And I think we've got some folks in the various non-transport side of things that are also trying to champion the improvement of the trauma system. And while it's not an overnight change, it's definitely noted in the past 17 years of my involvement in the system. And I think, you know, things such as the regional trauma grants that are allowing us at Caledonia to put on PHTLS as well as Beacon classes for everybody is a good start. And I'd love to see that expanded, especially when it comes to education. I think we have a lot of willing participants. What I would love to see is more involvement with hospital-based personnel in feedback to the individual end users or the end contributors to the system. And I'm not sure how that would look, but I think that's probably an area that wouldn't be unattainable. But I think those relationships could be built a little bit stronger and definitely open up those line of communications. And I don't know if the other fire providers on the call here would agree with that or have any better ideas for opening up those channels of communication. We usually get our follow-up through, at least in Kent County, through CHEMS. And the process for that is pretty easy, and anybody can request that information. But I'd love to see a more proactive approach of, hey, this patient came in, they originated in your jurisdiction. Here's what went well. Here's what maybe we could work on for future training ideas so that we could continue to improve the outcomes.
Thank you. One of the questions that has come up is the timing of the feedback and the content. You know, do you like just that down and dirty, the patient lives, here's what we found, what you want, what you did well, what you might improve on? Do you like to have the bigger picture of they were here 20 days, they had 10 surgeries, et cetera, whatever it is? Do you like that whole picture, or do you really like more that immediate finding and tell us what you want to hear and what about the timing of the feedback?
I personally like the big picture. I can take that and that information that we get and then debrief the other providers that were on that call, and we can dive deeper into the physiology. So we make it a learning opportunity overall. So everybody there benefits, but then I can take that to the entire department, anonymize it, and, you know, without providing details that are protected, be able to inform everybody on the department of what we found and what, you know, the how and the why that patient spent 25 days in the hospital, and what surgical interventions they had, and what stuff that leads to long term, because they may be a township resident. So chances are that once they're discharged from their rehab, we're going to see them again. So we have a healthier respect of their long term potential deficits and are better equipped to manage them as taxpayers and as long term users of our system.
That's an interesting perspective, Brian. Thank you.
So Yvonne, one thing that I just wanted to mention, and I think Jen was kind of on that line, if that's okay. Got a couple things. One is hopefully all of the EMS providers are aware that there is a way throughout the region to request information that's on the regional website. So if you go over to submit a report, once you get to the website, which is www.wmrmcc.org, if you click on the submit a report and then drop down to clinical information request, that goes to the local MCA or whoever the contact for that area is, and they're able to pass that off. Usually the process is pretty quick as long as you have somebody that's monitoring that, and most of the MCAs do. If you run into problems, just reach out to Damon, Chad, Rich, or I, and we can usually figure that out. And then the other thing is that Jennifer actually dumped into the chat, if you're able to get it. We also do have a recognition program submission list, and some MCAs are have a little bit more vibrant approach than others, but I think we've heard about it from all MCAs to be able to send that good feedback back to the providers, again, just to kind of continue to have that positive feedback and provide that information. So 2 great opportunities.
Yes, very important, especially the recognition. And at the scene, sometimes those are very key findings that make a whole difference in everything that we do from that point on. So yes, thanks for bringing that to our attention. Anyone else would like to contribute? We have about 5 minutes left. We really had this so that we could hear from those of you who are in the EMS pre-hospital situation.
Hey, Yvonne, can I make a comment? This is Amy.
Of course.
I appreciate the conversation, and I'm wondering if it's an opportunity to really put a small group together to have some more conversation and see if we can come up with some different plans on how to utilize or maybe communicate, as Lance just brought up, forms and different ways that we already have in place for people, and just to do a better job of that piece. I don't know if it's I especially appreciated Mo's comments about, how important it was because they don't hear that that information and that next step in the care. So I'd like to figure out if there's a way we can work together on that.
I think that's a great idea, Amy. How would you think about us having a discussion about it at the Regional Education Committee, and from that figuring out who would be the next steps for that? Because I do think there's huge opportunity here to bring us.
Maybe our next meeting we could before the meeting we can just send out just an open-ended invite to anybody that'd like to participate. Maybe we can get some more people at our meeting and to have that conversation and see if there's some different agencies that haven't been included or participated that may want to join us. That would be great.
Yes, I think that is a great idea. Helen and I will work on that as we put together the agenda. Do any of you come from outside of our region, from another region or another situation where they did it like super well and we could learn from them?
Hey, Yvonne, I just wanted to pick up on Amy's comment. I was wondering if we should do a better job of inviting EMS to our education meetings that happen our networking education sessions that happen at 10 o'clock before RTAC every other month.
Right.
And whether people would even be interested in that. Of course, it's not all EMS focused. It's, some of it's hospital PI, but especially when we get back in person, it might be a nice way to connect and develop relationships and be part of, trauma system development.
Well, we could make an effort too to expand some of that conversation, PI conversation, to be inclusive of EMS issues prior to arrival, et cetera, type thing.
Right.
For sure.
So we'll work on all of that. I think that those are great ideas.
Okay, well, any other questions? It's 10:58, so some of us have a meeting that we have to log on and log off and log back on. I want to say thank you to a couple of people. One to Lance for arranging for CEs. I know those are really important for our EMS attendees today, and so thank you. And thank you guys for attending. I'm sure this conversation could have gone on for a couple of hours, honestly. I feel like we just barely, touched the surface, and the conversation will continue, I promise that. I will send out some slides that unfortunately with a late start, I didn't get a chance to go over, but it really just gives you the briefest picture of the regional trauma network and kind of a brief explanation from the Michigan website. Helen provided that, and I would like to say a huge thanks to Helen. She's very behind the scenes in this organization at this point, perhaps, especially without us meeting in person, but she does a lot of work to organize us and put things together and meet with us outside of these Wednesdays, and is just very resourceful and helps us know the resources at the state. So I will send that information that she sent, as well as a list and a location of all of our presenters today. And thanks so much for those of you who presented. And we've all learned from that. So our next education session is October 13th. So we meet every other month on at the 10 o'clock hour. It is focused on education, and all of you are welcome. And there will be more that comes from Courtney in terms of topics focused on that particular month. So thank you so much, and look for an email from me that gives you that summary.
So
Thank
Yvonne,
you.
before
Thanks,
everybody,
Yvonne.
What? Go ahead, Lane.
before everybody logs off, just please take a look at the chat. There is the evaluation in there, and please complete that so we can get you your CE credits. The other thing too is if you miss it because the meeting closes, just send me an email and we'll make sure you get that link too. Thank you so much.
I will also put it in the thing that